Do you wish me to turn it on, or can you hear me? We're all good? Fantastic. And you can always just say yell. You know, it's that old saying, sleep on it, everything seems better in the morning. It's really true if you do actually sleep, or if you go into the right type of sleep. And science is showing us how prevalent sleep is. And it's not just about rest, it's not just about cheating those few hours. It actually is our health. I'm going to skip over, I've heard that you have a copy of my lecture, which is wonderful. I'm just going to skip over the disclosures. I am a paid advisor for pure calculations. When I was putting this together, and Denise asked me to speak on stress and depression and sleep, they really are a triad. You cannot treat one successfully without looking at the others. You can't try to help somebody sleep and not look at anxiety. You can't try to treat depression when somebody is not sleeping. These variables are so interconnected. And when I was looking at, usually I'm speaking, I hadn't spoken on this topic in Hong Kong, so I was doing more stats catered to here, and I was blown away. I thought North America was tough. You guys are very tough. 1 in 6 in Hong Kong suffer from clinical anxiety, depression, or mental illness. And up to 82% of people in Hong Kong experience general anxiety every single day on some level. The number of children under the age of 15 being hospitalized for mental illness has risen 50% in the last 6 years. These numbers have to stop. According to the World Health Organization, one of the leading causes of death in Hong Kong is actually suicide, and that is due to stress. This one blows me away too. Hong Kongers on average work 2,300 hours per year, compared to most industrialized countries, which are still overworking, and they're only at 1,700. You sleep 6.5 hours or less, and actually the majority of you guys are on the less side, maybe not within this room, but out there. Again, compared to the 8 hours per night. And 2/3 of people in Hong Kong suffer from stress-induced insomnia. According to the Anxiety Support Organization of Hong Kong, Hong Kongers are so crippled by stress that they actually can't leave their homes without feeling some symptom of it. This is not a way for us to live life. And this is what our patients are walking through the door with on a day in and day out basis. And there's so much that we can do about it. So why is stress so prevalent? Especially so much more than before. We are Fred Flintstone, and we're living in George Jetson's world. We are not designed for this world. We're hunter-gatherers. We're supposed to have one stressor a day. It lasts like an hour. We go hunting. What's happening in our society is we have several stressors all day long calling upon cortisol. So naturally, in our hunter-gatherer world, cortisol peaks at 6 to 8 a.m. in the morning. It says, great, get me up, let's go. It dissipates throughout the day. It's at its absolute lowest before we go into bed at night. And we'll go through all of those variables which it impacts so that we can go into a good stage for delta wave deep sleep. In our society though today, we are peaking cortisol all day long. Stuck in traffic, late for work, didn't sleep 8 hours, having a caffeinated sugary beverage, whatever that be, all the way up to big stressors such as illnesses, finances, etc. And this is shifting our natural circadian rhythm of cortisol, and it's peaking at 2 to 4 in the morning rather than peaking at 6 to 8 in the morning. And I always love this one with my patients when I say, well, how's your sleep? I say, not so great. I say, well, is it difficulties falling asleep or staying asleep? And if they say there's also difficulties staying asleep, well, do you wake between 2 to 4 in the morning? They look at you like you're psychic. Like, no, not so much. This is just your biochemistry, and you've shifted this natural circadian rhythm. But what's now happening is that this peak in cortisol is impairing all of our sleep all throughout the night. But then we have our real low crash at 6 to 8 a.m. in the morning when we're supposed to get up. We don't have that good drive. And then that sets the whole day off. What this has happened, this is really key. The impact biochemically that this has on the body is that loss of negative feedback. It is not about the ultimate level of a hormonal production. It's about the inability to turn off that hormonal production. So we know that when we have a stressor, stress hits the hypothalamus and it says, okay, I need to take myself from parasympathetic, the quiet side of the nervous system, into sympathetic, the stress side. So it dumps out CRH, which tells our pituitary to dump out ACTH, and the adrenals then make cortisol, adrenaline, and noradrenaline. After that 1 hour that we're supposed to be hunting for, that one single stressor per day, cortisol and adrenaline, noradrenaline, those catecholamines, they will bind into receptors around the hypothalamus and the pituitary, and that's the signal to the brain to say, okay, I'm done with the stressor. Stop stimulating this pathway, stop making more stress hormones. Until those hormones bind into these two glands, our body doesn't know that the stressor is resolved, and it just keeps stimulating this pathway. And as we saw on the last slide, we have so many stressors all day long that this is being bombarded all day long, that cortisol has two major effects with this. It increases the production of inflammatory cytokines, which we'll get into the huge impact with that. That inflames these receptors. So now these hormones can't bind into this receptor and shut this pathway off. So statistically, 90% of people living in industrialized countries are looping around this 24/7. They actually don't even need a stressor anymore because they can't shut off this pathway. And this is why patients will say, well, the stressor was 6 months ago or 2 years ago, and I'm past that now, but I'm still feeling this way. And it's because you can't get off this cycle. You can't deep breathe your way out of this. You can't take a holiday and get out of this. We have to biochemically unhook all of these receptors and allow these hormones to bind back in, and that's one of the tools that we have that we can use with patients. You can slow this treadmill of stress hormone production down by meditating, by deep breathing, by sleeping, etc. But you can't get off that treadmill until we fix those receptors. It is not good enough to use the supplement that just slows down the production of these guys. We have to use the supplement that targets these receptors, and that's one of the things that we'll be talking about today. The other really scary thing that cortisol does is it's actually been shown to cross the nuclear membrane, so the nucleus, go in there, bind to messenger RNA, and actually change it. So yes, cortisol is actually changing our DNA. It's called tagging a gene, and it will actually form a SNP or mutated gene from it. A really good example, lifestyle-wise, outside of the rats that we do this on. I always feel sorry for rats. I figure if I'm bad in this lifetime, I'm coming back as a rat, because they get all the nasty things in the lab. But there was just last year, there was a set of twins in the United States. One was an astronaut and one wasn't. One went up to space for 9 months. When he came down, 7% of his genetic coding had been altered because of the stress up in space. So there's physical and emotional stress up there. But again, when they compared it to his twin, it was 7% different, which is huge. Good news is there's something, again, that we can do about it. So there was a study out of Ohio State University, and they looked at over 170 genes, and they looked at the impact from stress on those genes. Every gene has an on and an off position. It's like a light switch. Sometimes we want the gene turned on, sometimes we want the gene off. Cortisol always changes that gene to its adverse position, so it's going to turn it off if we want it on, or on if we want it off. And this was one study showing that within the 170 genes, they looked at 100 of them were affected by cortisol being completely turned off. 90% of genes are turned down or turned up, but 100 in this, out of the 170 were turned off completely. And it's never the, oh, let's make my metabolism work better. It's not the, oh, let's affect my sleep in a deeper way. It's always in the adverse way. And in this study, it was always with wound healing, inflammation, metabolic sleep. In the reverse side, though, they did a quick study. They took 20 people, and they just did meditation and yoga with them for 20 weeks, so stress reduction there. And they looked at over 1,560 genes. In the novice people, so people who had never meditated or done yoga before, out of that 1,560 genes, 874 for health were upregulated, and 687 for stress were downregulated. So it had a positive effect in both ways. That's in people who had never meditated before, which is huge. Now again, when you stop that meditation, that cortisol will come right back up again because that doesn't fix that loop. But if we fix that loop, and then add in some of these lifestyle things, we're far better off. The experienced meditators had an even more significant effect with that. So what's exactly going on when we lose this feedback within the HPA axis? Well, we get to that place where we can't turn off. We can't get back into the parasympathetic side. We're chronically in the sympathetic drive, independent of what's going on. We don't even need a stressor there. With respect to what we're talking about today, we're going to see how that's going to impact melatonin production and timing of melatonin, which is going to impact sleep. It actually alters our microbiome directly, which then in turn increases our stress hormones. It directly increases the production of inflammation, actually by 76%, which is huge. And then it's also going to impact the hormones of stress and depression, which we'll get into. So with stress and anxiety, the main hormones that we're looking at are epinephrine, cortisol, and norepinephrine, once we start looping around that HPA axis. And one of the first things it does is it's more prominent with the fight side of the fight or flight reaction. So it's the panic, it's the worry. This is the person who their nervous system thinks that they are out hunting 24/7. So they are startled by more noises, bright lights. If somebody says something to them, even if it's their spouse, it might feel more like an attack because they're waiting to be attacked by the saber-toothed tiger. So everything gets augmented. When we're hunting, the last thing our brain wants us to do is go to sleep, because we might die once the tiger comes. So it's going to alter, and we'll get into this in great detail, the production of melatonin, but really inhibit the brain's ability to go into stage 4 sleep, that deep, rejuvenating sleep. It's going to have the melatonin peaks naturally at 2 a.m. in the morning. So that's why when we shift that cortisol, that's why we have the biggest peak there, because it's trying to say, no, 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 do not go into stage 4 sleep, do not even fall asleep. And so with the anxiety people, we'll see that waking at 2 to 4 in the morning. We may also have difficulties falling asleep, but we're definitely going to see the waking at 2 to 4. They also have those racing thoughts. They're stuck in beta wave activity. So we have three main forms of brainwave activity. We have alpha, which is like, hey, hanging out. And beta, which is, oh my God, I'm running through the forest. And then we have delta, which is the stage that we go into if we meditate properly or into deep sleep. These guys are stuck in beta wave all the time, and they can't have difficulties focusing in on one area again. And then they also have a lot of irritability, a lot of anger, a lot of overreaction. That's the main focus, but then it oscillates with depression. So depression is the flight side of the anxiety picture. Cortisol, as we'll also see, inhibits the production and the binding of serotonin, so the depression side starts to move in even more. But even if the serotonin is normal, you still will see depressive modes. It's just the anxiety picture is the bigger one, because that is the flight side of the fight or flight reaction. And it's, as we saw from the stats, it's not just in adults. Kids are going through this, and it's even worse when these hormonal shifts take place as a child. When we're growing up as a child, just as our immune system is educating itself, so we're supposed to be exposed to smaller bacteria so our immune system can mount a response to it and we can educate the immune system. The nervous system is no different. We're supposed to have small stressors as a child. My brother stole my doll, my crayons broke, those sort of things. And we learn to make this amount of stress hormone for that stressor. And then the stressors get bigger and bigger, but we don't have the exaggerated response to it because we learned at a young age, I only need this much stress hormone to be safe. If a child undergoes a great deal of stress, they learn this amount of stress hormone is the normal for any stressor. And they carry that with them all through their life unless we reset that HPA axis. So children who have gone through anxiety, we have seen the much higher rates down the road, panic disorders, general anxiety disorders, clinical depression, because of that larger amount of hormone that their nervous system learned to make. And it also greatly affects our microbiome. There's so much interesting research coming out about the microbiome and just how important it is, and it's not just about gas and bloating anymore. Our microbiome, it actually makes more neurotransmitters than our brain does. And this brain of the body communicates with this brain of the body through the vagus nerve. And so the hypothalamus up in the brain, it sort of scans our external environment to say, am I safe? Do I need to react to this? Do I need to flee? And if it says yes, I do, it sends a message down the vagus nerve to the gut to say, okay, let's start pumping out some inflammatory markers. The reason they come out is if I'm cut while I'm hunting for that saber-toothed tiger, I want to wall that off with inflammation, just in case there's any bacteria in it. When I get back to the campfire after my 1 hour of hunting, my stress hormones will go down and my inflammatory level will go down. The other message that gets sent here is now let's start to really increase the beginning fighting size of our immune system. So let's put our lymphocytes up, let's put our granulocytes up, let's put all of those beginning fighting guys. And if it's only up for an hour or two, not a problem. If it's up 24/7, we start to get into some big issues. Then this gut communicates what's going on inside the body. So do I have a bacteria here? Is there a fever going on? Is there a stressor inside my body? And if it says yes there is, or it identifies something, it sends a message up the vagus nerve to this brain to say, okay, let's make some more stress hormones. And when they start doing that, those stress hormones then go back down and wipe out back to the good bacteria again. We know that this communication takes place with the vagus nerve, because back to the rats again. We took, in the lab, they took two groups of rats, and they supplemented one group with Lactobacillus rhamnis, which is one that really helps to moderate stress hormone production in the GI tract, and then they didn't supplement the other group. And they put them into a forced swimming task, which rats don't really swim well, so it was a very stressful event. The group that got the Lactobacillus rhamnis, they had far lower levels of cortisol increase, far less erratic behavior, and then the big key with rats with stress is how much withdrawal behavior they have after the stressor is over. So the group that got the probiotics had they integrated right back into sort of normal behavior after the stressor was over relative to the other group. Then they repeated that exact same thing, but they performed vagotomies on all of them. So they cut off the vagus nerve. None of that took place. So they know that there was absolutely no communication between the two of them. When cortisol is around, the way that it kills off all the probiotics, or a lot of them, within the GI tract is through the production of those inflammatory cytokines. So our good bacteria, they have these, they're called lipopolysaccharide proteins. They are a recognition pattern system. So every good bacteria has a very specific coding with specific receptors to say, oh, I'm this kind of bacteria, I'm good, don't kill me. Versus a bad invading pathogen that are always in our body, they don't have this way. So this receptor system is a way that our immune system looks in our GI and says, oh, you're good, let's keep you. You're not so good, let's kill you. Cortisol, like how it inflames the hypothalamic and pituitary receptors, it also inflames the receptors on this polysaccharide coating around the probiotic. So now it doesn't look like self anymore, and the immune system comes in and kills those probiotics. When our probiotics are low, that's a signal of stress within the bowel, so it sends a message right back up to the vagus nerve, to the hypothalamus saying, let's make more stress hormones. And we know that it is the bacteria, again, that are doing this, because if they take a group of rats again, and they genetically modify them so they have absolutely no microbiome, and then you have a normal set of rats that has a set of microbiome, and you put them into, this test was done with an elevated plus maze, which is, it's a maze which looks like a plus, and it has open arms to it and closed arms. Open meaning not covered. Rats hate, oh sorry, this was mice, not rats. Mice really hate being in open spaces, so when they block off the covered arms, the mice are forced to go down the open space, and that acts as a big stressor. Those without, who were genetically modified with no microbiome, had really aberrant behavior when they're in the open arms. Their cortisol levels went through the roof, and again, they had much more withdrawal, just like rats do, all rodents do, after stress. Then what they did is they took those same rats that were genetically modified for no microbiome, and they did a microbiome transfer. So they put in microbiome from a normal, non-stressed rat into them, and again, the behavior was greatly modified. They did increase cortisol because they don't like that open arm, but not nearly as much. Their behavior was far less erratic. So we know that it's the microbiome, we know that it's communicating through the vagus nerve, and we know that stress impacts the microbiome. When the microbiome is low, it increases that stress. So again, it's another variable within this stress pathway that we have to consider with our patients. Stress also inflames but mutates the receptors around the hypothalamus. So even if those cytokines, those inflammatory cytokines haven't got out yet, those catecholamines still can't bind in because the receptor is mutated. So once again, we can't turn off that HPA axis. Cortisol also really increases glutamate activity. And glutamate is that, oh my God, oh my God. So in the brain, glutamate should be quickly converted into GABA. GABA nice and calming, glutamate is excitatory. Cortisol stops that conversion and increases the production of glutamate. It also reduces BDNF, brain-derived nerve factor. And this is sort of what's supposed to go around in the brain and mop up any mess, mop up any damage that's taken place. So whenever there's been inflammation or an insult to the brain or receptors mutated, BDNF should go over there and fix it so that that neuron can work again. Cortisol doesn't allow that to happen. So all of those pathways further keep that HPA stuck in sympathetic drive. And literally, stress is making us lose our mind. We have a gland in the brain called the hippocampus. It's our short-term memory, it's our focus guide. And cortisol will inhibit the production of neurotransmitters that bind into the hippocampus so that we can't focus in on one thing. And again, it makes sense as a hunter-gatherer. For that 1 hour, I don't want to focus in just here, because what if over here or here or here is the saber-toothed tiger? Once we get back to the campfire again, we'll start making those transmitters so that we can focus in on one thing. Left untreated, we have very little hippocampus stimulation. The hippocampus is a muscle, no different than going to the gym, lifting weights, the muscle grows. Stop lifting weight, the muscle atrophies. So we actually shrink the hippocampus to 1/3 of its size. The entire prefrontal cortex shrinks by 30%. It's huge, massive, just from stress. Good news is that once we stop the excess production of those stress hormones, we will start the neurotransmitter binding again, and then we will start growing that area. It also increases, as it decreases the hippocampal area, it stimulates the amygdala. And the amygdala is responsible for emotion. So this has happened, with what degree do I react to it? And when the amygdala is overstimulated, we have a lot more fear, a lot more worry, everything is augmented. And so with this overexcitation, the amygdala will actually grow. Cortisol also decreases repair, not just through BDNF, but when that saying, what fires together wires together. So when you learn 2 + 2 is 4, we don't learn it right away. We have to go over 2 + 2 = 4 over and over and over. And the more times we do it, we get dendritic growth in between those neurons until it's a little cable. Cortisol stops that growth of dendrites. So again, focus and concentration becomes very poor. But dendritic growth is also the way that we heal. That's how BDNF works. It increases dendritic and axonal growth to fix an area in the brain. So all of that damage that goes on from inflammation day in and day out can't be repaired. And there was a really good study. They did a 4-year study under functional MRI. And they found that those people at the beginning of the study who had a lot of activity within the amygdala and large amygdalas, later on down in life, they were the ones that had big panic attacks to smaller stressors, or general anxiety disorder that was triggered by smaller stressors, and they stayed with them their whole life. So how does this then jump into depression? Well, one, you can see that there's crossover of hormones, a lot of them. We've got the cortisol, the adrenaline, noradrenaline here again, or epinephrine, norepinephrine. But we also have serotonin, our happy hormone, and dopamine, our motivating hormone. And in depression, we have an imbalance between these hormones, which leads to a lack of joy. There's a lot of symptoms that overlay with depression and anxiety because the hormones are so similar. So you can get a lot of worry, you can get a lot of anxiety, but the people with just anxiety, who it hasn't morphed yet into depression, they can still find joy. So they'll still go out to an event, get excited, find joy. They might be stressed about it a little bit, or the next day something else might happen that they're stressed about. But the people who are really depressed, they can't find joy in anything. And that's very different than not being motivated. Dopamine is our motivating chemical messenger. Not being motivated is very, very different than not feeling joy. These guys are also going to have sleep disturbances, but with the true depression where serotonin is involved, we see more of a waking at 5 a.m. Now, if you're like me, that's my normal waking up. Anyways, just for work, so that wouldn't help us out there. But if you can sleep in, those people who are waking more at 5 a.m. as opposed to 2 to 4 in the morning, we know that things have morphed and serotonin is now involved, because serotonin should start to rise as we go towards the end of our sleep time. Again, lack of concentration, and and I'm not sure why, but there's a lot of guilt with serotonin. They might not be able to tell why, they might not be able to describe it, but there's a lot of guilt associated with it that we don't see with the anxiety patient. Depression also affects brain function and neuroplasticity. So cortisol, unlike epinephrine and norepinephrine, will inhibit the production and the binding of serotonin and dopamine, which is why clinically 90% of depression is secondary to anxiety. There's a very small, 10%, very small portion of the population who is genetically depressed. Most people, it is anxious depleting it, and that's why we see the similar pictures of hormones. In the inherited genetic depression, they have low serotonin, low adrenaline, low noradrenaline, always. In the stress anxiety picture depression, they have low serotonin, but higher adrenaline, higher noradrenaline, as well as cortisol. Stress-induced depression also changes brain function and brain repair. So yes, because of the cortisol, we're going to have a reduction in BDNF, so things can be mopped up as well. But with depression in this hormonal picture, we also see an increase in something called mitogen-activated kinase phosphatase. This is just an enzyme, which what it does is it decreases the ability of the brain to adapt to change. So they get very overwhelmed, very scattered, because they can't focus in on that, they can't adapt to change, and our world is changing all the time. Post-mortem, particularly in suicide cases, but in all depressive cases, MAPK1 is really elevated, much more so than in just the true anxiety patients. Which is a good screening tool if somebody is concerned about suicide with a patient, or because you can test these levels in blood with the MAPK. So it's a good screening tool as well to really know, are they serious with respect to the suicide. There's been some really good studies as well looking at the effect of cortisol on serotonin and its behaviors as well. So once again with rats, they injected cortisol, or as a placebo, saline, for 21 days to mimic chronic stress. And then what they did is they exposed them to cats. So they didn't, obviously they don't like the cats. And once again what they saw was those people who had, or those animals rather, at the 3 weeks that were injected with the cortisol were much more aggressive as soon as the cat came out. And then the big key here, much more so than the anxiety picture, huge withdrawal. These rats would actually just go into the corner and just sit. They wouldn't interact even for days afterwards with some of the other mice. So after any big stressor, the clinically depressed patient will really, really withdraw. And it's actually, what they found on biopsy with these rats was that there was very little glucose that was being transferred in the depressed rats to the hippocampus and to the amygdala and to the hypothalamus. And their theory was that it was a protective mechanism of the brain of, if I don't give you the fuel that you need to function, maybe we can downgrade some of the activity that's in there. But if you never turn that activity back on, then we get a lot of that withdrawal again, a lot of those depressive symptoms coming back. So long term, that equals depression. We also see a huge amount of inflammation. Cortisol increases the production of those inflammatory cytokines, those TNFs, those interleukins, CRPs, by actually up to 76%. And then this becomes a loop in of itself, because when we increase IL-6, that's a stimulus to increase TNF. When we increase TNF, that's a stimulus to increase IL-6. So that whole inflammatory pattern goes right around. And what do these cytokines do? Well, we saw that they inflame and mutate the receptors in the hypothalamus. We also saw their impact on the probiotics within the GI tract, but they will actually directly inhibit the production of dopamine and serotonin and their reuptake, and that's in a dose-dependent fashion. So again, the higher the inflammatory production, the lower the serotonin and dopamine. And then it's also, those cytokines also increase that glutamate, that beta wave brain chaos, as we call it. And if you look at depressive patients, they always, independent of whether they have an arthritis or a Crohn's or a colitis or an inflammatory condition, if you do their blood markers for ESR and CRP, so general inflammation, they always have a much significantly higher levels of those. One keynote, if you are going to do labs on your patients, the way that you can see low-grade chronic inflammation, because by the time CRP and ESR are up, you've been really inflamed for a long time. If you do a white blood cell screen, so just a regular CBC, if you start to see the lymphocytes and the monocytes rising, but the neutrophils going down, that's even within the normal range, that's a really good indication of chronic low-grade stress. Because the lymphocytes and the monocytes, there are T helper 1 guys that are trying to say, oh my God, fight. And the neutrophils are part of the T helper 2 side, the inflammatory side. So what you start to see is a reversal in that pattern. So again, that's another great way of checking low-grade inflammation within patients. Patients who are obese, we make a great deal of these inflammatory cytokines in our adipose tissue. So again, if you have an obese patient, their inflammatory cytokines are much higher. And those are often the patients that they're not going to respond to natural medications or drugs unless we fix this inflammatory picture, because still nothing can bind until that inflammatory load is down. The other thing that happens with stress and depression is cortisol inhibits the conversion of tryptophan into 5-HTP. So normally, tetrabiopterin 4, it takes tryptophan and converts it into 5-HTP, but cortisol decreases the production of BH4, so we can't get that pathway. 5-HTP is the precursor to serotonin. Serotonin is our precursor to melatonin, so we can see how this is again going to be linking into sleep. It also increases the production of IDO, which is the tryptophan going down into chiarine. IDO is an enzyme which takes the tryptophan away, doesn't allow it to go into 5-HTP, reroutes it through another route. So once again, we have yet another route where stress is lowering the production of our serotonin and increasing depression. So how does all of this affect sleep? You know, again, people are not giving the credence to the importance of sleep. And I've been a huge fan of sleep my whole life, so I'm thrilled that it's now really coming into the forefront. But just to show you how important it is, and granted, this is an extreme case, and this is a rare gene, but there's a gene, the PRNP gene, and it makes this prion protein. And what that does is it inhibits the ability to sleep. There is not one case of somebody living who expresses this gene. We cannot live without sleep. I mean, right there, that tells you how important it is. It has 4 stages. In the first stage, you just have bouts of insomnia that start increasing, panic attacks, start increasing hallucinations, and that progresses into really big panic attacks for the second stage, which lasts generally about 5 months. Then it goes into stage 3, where there is a complete inability to sleep. And this generally goes on for 2 to 3 months. Independent of any pharmaceutical drug, they're unable to sleep. and then it goes into dementia, unresponsiveness, and death. This is how, again, I understand it's an extreme, but like how we cannot live without food, like how we cannot live without air, we cannot live without sleep. And to say less food or less air, less oxygen in me is okay, it's really, less sleep in us is also not okay. So our sleep pattern is controlled by two main arenas. One is called sleep rhythm, and one is called sleep, oh my goodness, I'm blanking about it. Pressure, the next slide. Our sleep rhythm is controlled by our melatonin production, and we used to think that melatonin was solely controlled by the sun. It's greatly controlled by the sun, but we used to think it was only controlled by the sun. We now know that that's not the case. And when they looked at plants, but also a group of scientists locked themselves into a dark room for a month. Oh, it should be now. I mean, that would just kill me, but they locked themselves into a room for a month, 24-hour darkness, and they found that their natural circadian rhythms shifted by 2 hours, but it still stayed within a general clock. They're not sure as to where that control base is coming from, but they believe because sleep is so important, there's a lot of different backup mechanisms to control our sleep cycle. But in general, our production of melatonin is what controls our sleep cycle. And we make melatonin by being exposed to sunlight, which hits this SCN, the suprachiasmatic nuclei, which then sends a message to the pineal gland to say, okay, let's make melatonin. Not let's release it, not let's tell me how much, when I should sleep, or sorry, how deeply I should sleep, but moreover, how much are we going to make by the sunlight exposure, and then when I should start releasing it. So melatonin is not a sedative. If you have patients who take it and they walk in and they're like, it didn't work, I didn't sleep. Not surprised, it's not a sedative. Once you are asleep, melatonin pushes us into that good stage 4 deep sleep where our body heals. It does help reset the timing of sleep, and it does help calm the body down. It relaxes the body, but a relaxant is very different than a sedative. Melatonin should start, as sunset falls, should start to be released, and its peak is released at 2 in the morning. Again, it's supposed to counterbalance that cortisol curve. We also have sleep pressure, and sleep pressure is controlled by a neuromodulator called adenosine. And adenosine builds up over the day as we haven't slept. And it is a sort of make me groggy, inhibit stimulation, so that we're more tired at nighttime to go into bed. And then as we sleep, our adenosine production drops so that we're more awake and more alert in the morning to wake up. If you have cortisol coming out in you all day long, it inhibits the production of adenosine. So you get to nighttime and you're not tired, you're not sleepy, your brain can't fall into that sleep pattern. Or if you do make the adenosine, but you just keep working longer hours and don't let your body go to sleep, adenosine becomes very inflammatory at high levels in the brain, which then in turn also turns on cortisol. Sugar also really blocks the production of adenosine. So again, kids who are eating a lot of sugar, or even adults, very poor for sleep. And caffeine as well. So again, we see this inverse curve between cortisol and melatonin. Melatonin sleep, cortisol awake. The two of them will never be parallel. So how does melatonin affect, or how does cortisol affect melatonin? So we know that cortisol makes those inflammatory guys, those cytokines. And what it will also do is actually, those inflammatory guys will bind right onto the SCN, and they'll alter the production and the timing of melatonin. So they actually reset the whole pattern. So when we're first exposed to melatonin, or to light rather, we just make a little bit of melatonin. And as the day progresses, we make more and more and more. The minute we get cortisol, it takes us back to here. So that by the time nighttime comes, we have very little melatonin in us and very little production of or good sleep. With respect to sleep, there's 5 stages. 1, 2, 3, 4, and REM. 4 is deep sleep. It's all that matters. 1, 2, and 3, fluffy. REM is wakeful sleep. It has the exact same brainwave activity as we all do right here sitting in this room. It's useless. It's all about stage 4. The other thing that melatonin does is it helps us transition from stage 3 into stage 4. And that's where we heal. Sitting here, we're all resting, we're not healing. Only when we go into delta wave stage 4 sleep does our immune system go, oh, I need to make an antibody to fight that. I need to repair this muscle from working out. Anything that takes place is stage 4 sleep. And there was a really good study that was done on cancer patients. They compared them to normal, so cancer was the stressor. They looked at cortisol levels, they looked at the amount of stage 4 sleep, and then the immune responses. Hands down, when they compared the cancer versus non-cancer group, all of these guys had much higher levels of cortisol. They had very little stage 4 sleep compared to the normals, and their immune markers dropped by up to I believe it was 68%. I can't quite remember the stat for that one. Then what they did is they examined those numbers within each group. They said, okay, well, cancer's a really big stressor, so that might not be a fair assessment. So within each group, let's also look at the same stats. So within the normal group, those people that had the highest levels of cortisol had the least amount of stage 4 sleep and the lowest immune outcome. Similarly, the same was within the cancer group. So again, they knew that it was the cortisol melatonin picture impairing the stage 4 sleep and impairing our ability to repair our body. So as we see here, if we jump to this guy over here, the first guy, this is the depressed or anxious patient, and this is the normal. Our cortisol should be rock bottom low at 2 to 4 in the morning, but you see how high it is in the depressed and the anxious patients. And if we look over on the far, on the other end of it, we see melatonin should peak, again, at 2 to 4 in the morning, but we see how low it is down with these people. So no wonder there's all of these sleep patients with anxiety or depression, or the reverse. This is why you cannot treat one of those three. This is why it is that terrible triad. You've got to treat them all together. We can't not. Because if we leave the cortisol up, the melatonin is never going to fix. Or if you just give a bunch of melatonin and don't fix the cortisol, it's going to inflame all the receptors and still not allow anything to bind in. Depression and anxiety, and I've said this many times, they have the same hormonal theme to it. So, and symptoms. They all have associated sleep disorders. They have elevated cortisol. They have either too high or too low epinephrine and norepinephrine, and they have HPA dysfunction. With respect to cortisol, there is this misnomer that hypoadrenal has low cortisol. They don't. They have flatlined cortisol. They have low adrenaline and noradrenaline, but cortisol should peak at 6 to 8 a.m. and then pretty much plummet right away and almost be flat for the rest of the day, and then definitely flat for the night. They have elevated cortisol, not as high as that 6 to 8 a.m. peak, but it's flatlined all day. So if you were to take the area under the curve, their 24-hour output of cortisol is significantly higher than the others, than the normal patient, because they're never getting that peak back down. If you take a chronic insomnia patient who hasn't been diagnosed with anxiety or depression yet, they still have the same hormonal picture that is going on. They still have the elevated cortisol. They still have the lower serotonin with them, and then particularly the higher cortisol leading and peaking at 2 to 4 in the morning. So they might not be anxious from a psychological point of view, but the hormonal picture is exactly the same. And it has now been clinically proven that it is this elevation in cortisol that is the primary cause of insomnia for all of these different reasons that we spoke about. And then that increases CRH, which is that hormone from the hypothalamus, stimulating that HPA axis all the next day. So all day long, after no sleep, we're just saying stress hormones keep coming out and out and out, which then impairs the sleep again the next day. Our environment also has a huge impact. As mentioned, we're hunter-gatherers. We're not designed for this 24/7. We are not designed for artificial lights 24/7. We're supposed to be at the campfire with natural light. And that's also messing up our melatonin production. And one study that they did was they took a group of people living in a city and they put them into, it was just for, I think it was just a week. They put them into 12 hours of daylight, 12 hours of darkness. So shifted artificial light back and forth. And what they found was that their peak in melatonin was peaking at 4 a.m. as opposed to 2 a.m. So again, what was happening was there was less stimuli there, less natural stimuli, so there was resetting of that melatonin production. Remember how I mentioned it would go back to its normal, so it takes longer to get to that peak. The problem is that during the first few hours of sleep, stage 4 is supposed to be dominant. We're supposed to spend more time in it than any of the other cycles. And then it's less dominant in the second half of the sleep when we're supposed to be rejuvenated and waking up. So if your melatonin is peaking at 4 in the morning as opposed to 2 in the morning, you simply do not have enough hours then to get the amount of stage 4 sleep that we need. Then they took the same group of people and said, go back to your life. Just do exactly what you're doing. Use your cell phones, use your iPads at night, artificial light, etc. Same thing. They were still peaking at 4 in the morning, which means most of us are peaking at 4 in the morning if we're not supplementing with melatonin. Then they took those same group of people and they took them literally to a campfire where their only nighttime light was a campfire. So they were woken up with the sun, and literally within 7 days, within 1 week, their melatonin curve shifted back to normal, stage 4 sleep increased. So again, it's, even if we're escaping stress, which very few of us are, we also have environmental impacts on us. I don't wake up at night to check my emails. I automatically have it forward to the people in my dreams so they can read it to me. I am blown away by the number of patients that come in and I'll say, well, how long are you up for when you wake in the middle of the night? I'm not really sure because I pick up my iPad and I do my email. Oh my God. Like, no, that's one of the worst things that you can do. So the other, as Denise mentioned, the other important factor with this, and for me it weaves its way through everything, is genetics. And the reason is, as Denise mentioned, I have a bunch of books. I actually don't carry any of them anymore because they're dietary protocols. They are, the stress solution one might be okay, but there is no one protocol for one patient. And that's particularly when it comes to diet. Because genetics, we're all different. The biggest thing to learn with genetics is just because you have a gene does not mean that you are going to express it. It might never get turned on, you might never turn it on. So the first thing when patients say to me, I'm really scared to hear what my genes have to say, we can turn everything off if we don't want it, and that's the beauty of it. That's where also as a clinician we have to look at our patients and match the symptoms of that gene with the actual gene to see if they're expressing it, whether we match it with symptoms or labs, etc. If you don't do genetic testing, you can still use this information in your practice. For instance, when we look at some of the stress genes, there are some people that make more than the normal amount of stress hormone for each stressor, independent of what happened to them as a child, because of their genes. Those are people who are more susceptible to anxiety, depression, sleep disorders, etc. If you treat a patient for any condition, anxiety being one of them, you reset their HbA axis, their symptoms all go away, barring that their lifestyle wasn't horrific, and you take away the supplement, they're generally somebody who has a SNP at that gene. They can or cannot make that hormone, so we might need to do some support. So you can look at these genes that we're going to go through, look at the symptoms, and look at your patient going, why every time when I decrease that dose just a little bit, is it coming? Well, we might need to actually keep you on the higher dose. Whereas some patients, you can reset it, take them off, and they're good to go. So that gives us a little bit of a clue. What is a SNP? As we know, our genes are located on our chromosomes, and they're made up of one of those 4 base nucleotides, the A, C, T, and Gs. And when a cell divides, it makes an exact replica of itself, and then it divides in 2, so we have identical copies. But sometimes there is like a little genetic typo, so we swap out one of those nucleotides for a different one. And the purpose of a gene is to make a protein. So when we change the recipe for that protein, because we've changed that nucleotide base, we now make a different protein. Sometimes that has huge effects on the body, sometimes it has absolutely no effects. Sometimes the protein is pretty much irrelevant, and that gene was pretty much irrelevant. Sometimes it's huge. Sometimes it's increased inflammation, increased cancer risks. decreased metabolic function. It can be anything or nothing. And that's the other important part to know with genetics is, where do I start if you're just new into it or thinking about going into it? Cortisol, as we mentioned, affects 90% of genes. So if you want to affect somebody's genes, just reset their cortisol. It's a huge way. You also can't have a proper functioning gene, independent of what it is, if we don't methylate. And methylation is a catalyst for absolutely everything in the body. It has a huge impact on neurological diseases and cardiovascular diseases, but it's really the powerhouse of every single reaction in the body. So if we don't methylate, and you give every precursor to make serotonin, they're not going to make the serotonin because they need that methylation to do it. So you'll see in some of the pure encapsulation products that we talk about, they have all the precursors to the hormones plus the methylated factors. So we know that you're going to do it. You can also, one of my favorites is to just blanket across the board, because you doing it this way, you can't over methylate somebody. Pure Genomics multivitamin. So it's a multivitamin by pure encapsulation with a genetic twist to it. So it uses the methylfolate as opposed to regular folate. It uses adenosine and hydroxy B12 as opposed to methyl B12, because adenosine and hydroxy will automatically convert into methyl B12 on an as needed basis. With straight methyl B12, you can over-methylate somebody. This multivitamin also has the natural and active versions of A and E, and so it's a really good. I'm going to make sure you're methylating at a normal rate, and then I'm going to treat cortisol, and you've already done that person's genetics outside of testing anything. A wonder of good. So what are some of these genes that we're talking about? The ADRA gene, there's a whole series of them. There's ADRA2, ADRA-B3, ADRA2, 3, there's lots of different ones. 5 that are really clinically significant, and this is one example. If you are also looking up genes from raw data, so you didn't get back a pre-color-coded printout from your genetic company, which has your green, your red, or your yellow, etc., what you want to do is plug in the RS number, which is this guy right here, into a browse raw data, and it will bring up just this one gene. There are more nonsense genes than there are clinically relevant genes. So if you use a company, and I don't think you guys can use it here, but 23andMe, they have a lot of the clinically relevant, well, they have a ton of nonsense genes. So you get back 55 different MTHFR genes, which is a methylation gene, only 2 are clinically relevant. So you got to know which genes are there. So if you're ever going to look into the genes we're talking about tonight, it's that RS number which identifies just the clinically relevant one. So this is the production of adrenaline, noradrenaline, and cortisol. So the 3 stress hormones through the adrenals. The ADRA2A person, the A allele, so again, they can have 2 A alleles. They can be that's called homozygote variant. They can have 1 of each allele, so an A and a G, that's heterozygote. And then they can have 2 G alleles, which is, quote, the normal position. The A allele is associated with higher levels of stress hormone production for each stressor. So these people are going to have impaired metabolisms, impaired sleep patterns, more anxiety, more depression, altered gut biome. Cortisol will triple the release of insulin to all grains, starches, sweets, and fruits, which means 1 apple gets treated like 3 apples, 1 bit of rice like 3 bits of rice. It alters adiponectin, leptin, and ghrelin are 3 hormones that entirely control the metabolism, dropping the rate of fat burning from 92% down to 35%. So when we have these patients who are walking in and they're gaining weight and they're really stressed and they're not responding to anything, these are the reasons why, or the ones my heart breaks with them. They're like, really, I'm not eating anything. They've come, from their other doctors who have said, well, I don't believe you, you must be sneaking food. They're not sneaking food. They're just, their body's treating it like 3 times that amount, and then they're not metabolizing it at its normal rate. We'll also see a lot of mast cell degranulation. So mast cells are the cells that line the GI tract, they line the skin, they line the sinuses, they pump out the histamine, so they're responsible for rashes, eczema, rhinitis. They also pump out cytokines. also see, again, people who are stressed, more inflamed and more susceptible to asthma and allergies. Then we have another set of genes. There's two of them. There's CRCH, cortical releasing hormone. So this again is that hormone from the hypothalamus stimulating that pathway down. The A allele here is the variant allele, and these people that they make more CRH for every stressor. So they're just stimulating their HPA axis at a higher level for a smaller stressor. So we have, again, increased ability to lose that feedback loop, more depression, more panic attacks. Ironically though, these are the people that respond really well to antidepressants and anti-anxieties because the majority of them will function on the HPA. They also have that altered sleep pattern, waking between 2 to 4. We have TPH2, tryptophan hydroxylase 2. This is an enzyme that converts tryptophan into 5-HTP, and then 5-HTP goes into serotonin. There is also a TPH1. TPH2 exists mostly in the brain. TPH1 is the production of serotonin in the GI tract. So we do have two different genes which control it. But in both of them, you will see more depression, more sleep disorders, waking up more at 5 in the morning. In both of them, a lot of muscle myalgia, edema, inflammation, which is why antidepressants are used so much for fibromyalgia. It's a cortisol and serotonin condition. We're now seeing that that's the majority of it. It's not the DHEA, it's not the growth hormone that we used to think it was. It's more the serotonin. These people will also have a lot of IBS symptoms, a lot of bloating and gas, because serotonin helps to regulate that. And again, the sleep patterns. DRD2, this is the production of dopamine. Dopamine is our motivating chemical messenger. It is our reward chemical messenger and our addictive chemical messenger. So when we have somebody who has a SNP here, which is the T variant, they make very little dopamine and they have very few dopamine receptors. So what happens is they don't have a lot of satisfaction. So they're always looking for satisfaction. They're always looking for that hit of something, which is why they create so many of the alcoholics. So God bless those who go through Alcoholics Anonymous and then get off of alcohol. But unless you fix the dopamine, they have invariably just switched it over to another form of addiction. They've gone to food, they've gone to gambling, they've gone to sex, they've gone to exercise. Exercise really increases dopamine. Great way to control it. But if you have a patient who needs to do it and is over-exercising, you have to think about dopamine, which is why it's a prominent one as well in anorexia as well. The foods that are released with dopamine are the fattier, savory foods. They're the cheese, the nuts, the wine, the chips. Very different than the low serotonin foods, which are the sweets, the pastries, and the chocolate. So I'll play this little game with my patients if I'm trying to test their levels or do their genetics, and I'll say, throw health out the window. If I put in front of you cheese or cookies, which would you take? If they choose the cheese, it's dopamine, lower dopamine. If they choose the cookies, it's a lower serotonin. And then I'll say, okay, we'll take it up a notch. At dinner, if you could only have a glass of wine or dessert, which one would you have? If they choose the glass of wine, they're the dopamine person. If they choose the dessert, they're the more serotonin person. Then there's the person who is leptin deficient. Leptin is the hormone which is released after each meal, which is great. I'm done. I'm satisfied. I don't need to eat anymore. Start my fat burning. The patient who says, oh my God, I can't choose. I want both of those all the time. They're the leptin deficient people. Very, very different than just straight dopamine versus serotonin. The other thing that we'll see with these people, and I'm one of these people, I could live off of cheese and nuts and wine if you let me. I don't, but I wish I could, is they're seeking out what we think of as adrenaline highs. So when I'm skiing, I'm always looking for the cliff to jump off of. I don't want to die. I want to make sure there's a big pile of snow there, but I want that high of going off of it. And then very quickly, I want that high again. So again, what we think of as an adrenaline high is actually more of a dopamine issue. They also have learning disabilities. Dopamine should stay in the prefrontal cortex to help us focus, concentrate, wire those messagings together. People with a T variant, not only do they make less dopamine, they actually transport, they have increased, they're called dopamine transporters, They take a lot of that dopamine out of the prefrontal cortex, shunt it into the anterior striatum, a different area of the brain, which is all about emotion. So we're taking it from focus and learning into emotion. Sort of if you think about the ADD, ADHD behavior, when they're on, most of the meds work through dopamine. So you think about them focused, and you think about them unfocused. GAD1. This is the gene which converts and helps convert glutamate into GABA. So again, glutamate is that, oh my God, into GABA, which is just, hey, I'm hanging out and I'm fine. GABA is also responsible for controlling muscle contractions, decreasing tremors. So we see this gene greatly in Parkinson's as well as in MS. We'll also have a lot of difficulties turning off racing thoughts with this because they're stuck in beta wave activity. We need GABA to sleep. We have to have GABA to sleep. GABA is what helps bind into that PPR receptor, that calming receptor. But without GABA, we actually cannot quiet the nervous system enough to sleep. These people will be very, very quick to anger. This is one of the biggest genes in major depressive disorders because glutamate, high glutamate, soon turns into serotonin syndrome in the brain. That and what's called deep derealization, which is a serotonin deficiency, all created by the chaos of glutamate. We'll also see a lot of muscle rigidity and a lot of different tremors. COMT. This is one of the methylation genes, but this is a gene which breaks down and clears out adrenaline, noradrenaline, and dopamine. So we always, when we look at genes and hormone production, we have to look at the two sides of it. So if somebody's making a lot of stress hormone, we have to look at that. But if they're also clearing it out really quickly, the end game might be balance. If they're making a lot and then they have a SNP in this, which is the MET or the G allele, they're not clearing it out. That's an even bigger impact on it. It also clears out estrogen, this gene. So again, people who can't clear out estrogen, increased risk of cancers there. These are the people that will tend to worry all the time. Again, they're more susceptible to stress. But ironically, they improve temporarily their alertness with stress. And that's because adrenaline, noradrenaline, which comes out with this or that they're not clearing out, under stress will actually focus the hippocampus. Cortisol won't, but adrenaline and noradrenaline will. When adrenaline and noradrenaline and cortisol all come out for a stressor, adrenaline and noradrenaline are active for 3 minutes, then they start to get broken down for this gene. When cortisol comes out, it's active for 8 hours. So if you think about how many times we're stressed during the day, and each of those times it lasts for 8 hours, it's we're not getting off that cortisol cycle. Cry1, cryptochrome 1. This is a gene which makes a protein that affects our clock genes, so our circadian rhythm. And this gene, the cryptochrome 1, really inhibits the ability for people to shift from one stage of sleep into the next, particularly from going to sleep into one or from REM into one. And it can often take them 2.5 hours alone just to shift in between cycles. So if you look at that timing, they're only through stage 1 or 2 sleep and the whole night's up if it's taking them 2.5 hours to shift from one cycle. They haven't even gotten into stage 4 yet. So that's having a huge impact on their body. And then we have the clock genes, which the cryptochrome 1 regulates. Clock genes will regulate our wake-sleep cycle. They will help transition us into stage 4 sleep. And they also play a huge role in the production of all hormones in the body. So every hormone, whether it's our thyroid hormone, whether it's production of cholesterol, whether it's our metabolic hormones, they take the cue from sleep, which is why sleeping, apart from sleeping normal hours and similar hours is so important in the number of hours, but the bigger component is your waking time. Shifting your waking time by 90 minutes is far worse for you than not getting that actual 90 minutes of sleep because it offsets the timing and production of almost every other hormone. A lot of the studies in this arena have been done in metabolics, and they show that people who eat the exact same diet, exercise the exact same amount, still sleep the exact same number of hours, so still sleeping 8 hours a night, but they shift their waking time by 90 minutes or more back and forth. they have an increased release of insulin by 40% within 4 days. They have an increase in BMI by 30%. The effects are so profound just from waking. So often I'll always say to patients, I don't want you to waste 4 to 5 hours by shifting it, but I would rather you get up at the same time and lose that extra hour of sleep, because that's actually less detrimental. Ideally, you'd go to bed at the same time, still wake up at the same time, and still get the 8 hours. So, before we get into treatment, are there any questions on anything that we've sort of gone through so far in terms of the science side of it?
Sorry, do you mind explaining the 90-minute shift again?
Absolutely. So independent of the number of hours one is sleeping, the body likes to wake up at the same time every day. So 7, not 8:30. If you wake up at 7:45 and 7 is your normal time, the effects don't appear to happen. The effects start to kick in at 90 minutes off of your normal waking time. And the effects are alterations in almost all of the production of our hormones, but the metabolic ones massively, being adiponectin, leptin, and ghrelin. And so just by shifting the waking time by 90 minutes, even if you're getting the 8 hours, you increase the release of insulin within 4 days by 30%, and all of those various metabolic changes that we saw. So it's much better again to wake up at that same time or closer to that same time.
Is 90 minutes one cycle?
So most cycles are 90 to 120. 90 is the general rule, but if there's a snip within the clock for the cryptochrome 1, it can be a little bit longer, but generally it's 90 minutes in one cycle. Absolutely, yeah.
So you mentioned the symptoms kind of came in more from like 4 days. So if you were like shifting on the weekend, is that still just as bad, or is it more consecutive?
They just start to kick in, yes. The major symptoms will kick in at 4 days, the insulin production.
Right.
But within 1 day, within 24 hours, your adiponectin production and your leptin will start to drop. It's amazing how quickly it happens.
So for those people who are on shifts,
so
what
hard.
happened to the insulin?
Well, it's why we see so much obesity and diabetes with shift workers. That's where we really need to keep the HPA axis happy. So we're going to go through how to do that, and we need to plow them with high doses of melatonin. So one of do I do the cheat thing? We spend more of the first few hours of sleep in stage 4 sleep. So even though the cycles are 90 minutes, the amount of time at the first few hours of sleep, it's like stage 1, stage 2, stage 3, stage 4, REM, and back to that. The second half of sleep is stage 1, stage 2, stage 3, stage 4, because we've done our repairing. Melatonin pushes us into stage 4. All the detrimental effects come from not having stage 4. It's just that we generally need the 8 hours and those cycles. So with those people, I will high dose them melatonin, like 10 to 12 milligrams, not the cancer, Alzheimer's, 20 milligram doses, to cheat their sleep because they're going back and forth all the time. And because it's their job. And you know, that's one of the realities with our patients is, and ourselves. It's, I don't know, 8 in the morning for me right now. So it is what it is. You do what you have to do, and we try to be kind to our body and use what tools we have. So for those shift workers, I'm way up there. And one little pure encapsulation plug here. I don't know what other companies you have for melatonin, but melatonin through Pure is far superior than almost any of the other companies that we have in North America. I'll have patients come in, they'll buy it from my office, they'll use it, they'll run out, and then they'll just go to the store and get a different brand, but it could be a good brand. Every single one of them comes back and gets the Pure. I don't know what Pure is doing with it. The quality is outstanding, and it really is a significant difference. Even when they were tested in labs in terms of purity and how much bioavailability was in it, even when that was the same, the starting raw material that Pure uses is outstanding. And that's often where I'll say to patients, I'm okay if you use an essential fat from this company or this or whatever it might be, melatonin for me is one of those non-negotiable guys. I will always insist that it's pure.
Can I ask you a question?
Of course.
A lot of people that work in finance in Hong Kong just say they check the American market.
Yeah, we have to reverse their checking the Asian markets.
They'll check the American market at say 8 p.m. and then they might be on to 1:30 a.m. And then some guys, if they're high management, potentially might have to check again. So those guys really don't get very experienced. One of those strategies
Absolutely.
is to sleep bank, to use a shitty analogy, is to sleep bank on the weekends.
So
in that case, based on, well, that BMI keeps sense in the body, you're sure to stay but the other stuff, what would you say to those guys?
So that's where I would high dose the melatonin again and high dose the serotonin. The beauty of melatonin, because it's not a sedative, they can wake up. So if they're setting an alarm so that they can check things, they can wake up like that. Or the mother who has a child and they're worried about taking it and not waking up, you can wake up with melatonin very easily because it's not a sedative. The beauty of it is that when you go back to sleep, you're going to quickly go back into that stage 4. So he's still going to maximize the amount of stage 4 that he gets. And the higher the dose you go, the more of that you'll get in the first hours of sleep.
You just take that once a week?
Just once.
Say 11?
Yeah. I often like to use a time-released version. So they're going to get little bits. Yes, there is a time, the SR, slow release, somewhere. They do have this, it's called melatonin SR, thank you. And it's a slow release, so I'll high dose that at the beginning of the night for people like that. And then definitely use what we're going to talk about, which is up here as well, Serotonin Plus, to reset that HPA axis. Because we can give them all the melatonin they want, but if their cortisol levels are up, and then that individual is going to be up, melatonin is not going to bind in and have its effect. So I'm going to tag team the Serotonin Plus at night, and maybe even again at 2 in the morning when they're checking a set, and then high dose melatonin just once.
And then sorry, back to the weekends, sleep bank,
Yeah, the research shows.
You say sleep in and have a nap in the afternoon.
Yeah, I'd rather them actually have a nap in the afternoon. Research shows that longer than 8.5 hours is actually detrimental to us. So less than 7 or longer than 8.5 is actually going to have similar effects to sleep deprivation. So I'd rather them do around 8 on the weekends and then do a little nap in between.
And naps, it's one cycle or
if they can, so
cycle?
generally if you can keep it into one cycle, so in 90 minutes, but again, genetics will show us some people it's a 120 cycle. The body will never on its own wake up out of stage 4 sleep. So if somebody is taking melatonin and their alarm goes off and they happen to be in stage 4 sleep when the alarm went off, they will be groggy for about half an hour to an hour. And that's another thing I hear with melatonin is I'm really groggy when I wake up. It's not actually the melatonin, it's that when you first start taking it and you go into stage 4 sleep, that's when you're going to start to bank and make up for that lost stage 4 sleep. So you'll spend more than the normal amount of hours all night in stage 4 until you catch up. So the chances of you waking up from your alarm in stage 4 are much higher. They shouldn't feel groggy with it when they wake up. So for the nap, what I generally like to say is let their body be the guide. Now, if it's going on for 3 to 4 hours, have this spouse wake them up because that's just going to impair the sleep in the nighttime. The other misnomer here with melatonin is it gives me really bad dreams. REM sleep is dream sleep, and that's the stage right after stage 4. So with melatonin, they've gone into stage 4 sleep, so they're going to go into REM. But if you don't reset the cortisol, the fight or flight hormone, all the dreams are really vivid and active. It's not a surprise. You reset that HPA axis, then they go into the stage 4 sleep and they have the normal sort of moderated. They might not be walking down the beach, but they're just not like that. So
Do you ever find there's a bit of dependency on it if they're taking it longer term?
Another good question. Thank you. I should have said that. No, it's psychological dependency. So there is no feedback loop with the pineal gland. So how there's a feedback loop with the HPA axis, or there's a feedback loop with the thyroid. Our thyroid is continually scanning for T3, T4 levels to then dictate how much it's going to make. So if we give somebody with a normal thyroid hormone, it teaches the thyroid not to make it, the feedback loop. There's no feedback loop with pineal. Pineal gland is not scanning the body for melatonin at all. Melatonin is solely made from that light stimulation, from the SEN, but it's still not a feedback loop. When it drops, the sun, when we go into darkness, that's when the pineal gland starts to release it. But there's nothing saying, oh, I actually released too much there, or I have some, let's hold on to this. So you can never teach your pineal gland not to make melatonin. The only way we can teach the body not to make melatonin is actually the colon also makes a bunch of melatonin. Taking melatonin is really good for colon cancer, Crohn's, colitis, because it's anti-inflammatory in the colon, but it won't, there's still no feedback loop there. But if we're inflamed in the colon, we really drop that production of melatonin. Really great questions though, because I often forget to say those in the really important points.
A couple of years ago, there was an article about melatonin increasing feminization in babies. I think it was like some action on estrogen. Do you know anything? I mean, I don't know.
It would have to be through estrogen, but I can't.
Because there was a warning, as such, you know, about maybe breastfeeding mothers with, you know, some issue about young boys and less testosterone with increased melatonin.
With the increased melatonin?
Well, that was, I mean, look,
I'm going to go look that up because that's definitely.
Yeah, and I think people, often in studies they focus on one thing, which, you know, in the medical.
They forget to negate all of the pesticides they may be consuming that are estrogenic in nature. And I'm going to look that up. I haven't heard of that. I can't think of a mechanism of action there that would increase estrogen. Because if anything, by giving melatonin and increasing your stage 4 sleep, you're going to perfect shifting 4-hydroxyestrogen into 2, your clearance of it.
Because there seemed to be a real shift just a year, probably 2 years ago, a real shift in that idea that no, melatonin is anti-inflammatory, it is antioxidant, you know, and it's that. But there was this big warning aspect.
So in North America, melatonin was banned for way back, and this may be where this is coming from, but the idea was it's not safe because it's a hormone. And the minute we think hormone, we think estrogen. The minute we think estrogen, we think cancer. There's this big loop. We forget that cortisol is a hormone, cholesterol is a hormone. Like there's good and bad and neutral. So that was why it was banned for a long time, without any just cause of seeing any estrogenic nature. It was just that, ooh, hormone, cancer.
I think this was more specific, but I can't
Yeah, it sounds like it was, particularly if you're getting more dihydrotestosterone.
Yeah.
I don't know. I'm going to look that up. And I will get back to Denise if I find an answer, and then she can get back to you. Now I'm intrigued.
Because it was just, and there was the sparking, and I remember getting asked quite a lot about it and thinking, okay, perhaps we need to be careful.
See, because melatonin inhibits the 4-hydroxyestrogen receptor, so it actually blocks it. 4-hydroxy being an acetylene. So it doesn't, which is why melatonin is actually specifically used for estrogen receptor cancers to lower estrogen levels. It also increases apoptosis from a cancer point of view. That's got nothing to do with estrogen, but it actually blocks that receptor and its effects in the body. So I can't see how, again, feminization would happen with that. But I am going to look that up because that's been bugging me. Okay. So what are we going to do with all of this? How are we going to fix all of this? We have to reset that HPA axis. We cannot just slow down the production of the stress hormones. We can't just temporarily decrease their production. We have to get our patients back to the parasympathetic side so that we can normally regulate the cortisol, adrenaline, and noradrenaline. We need to balance out that serotonin and dopamine side. We need to increase and regulate their melatonin production. And then we have to reset that gut flora because all 4 of those elements equal full health. So one of the first things that we're going to use is something called Serotonin Plus, which is, oh, there, this guy. It has 2 main ingredients, lactium and theanine. Lactium is an amino acid which is extracted from dairy. So over here, genetically, in Asia, there's a lot more dairy SNPs, a lot more genetics that people cannot break down dairy than in other countries. In order for our immune system to recognize anything, and dairy, but anything, it has to be 12 amino acids or longer. Anything that is shorter than 12 amino acids, the body cannot recognize. Lactium is 10 amino acids. So when you take it, it scoots under the radar of the immune system. So all my patients who are dairy sensitive, dairy intolerant, dairy allergic have absolutely no issues taking this because the immune system can't recognize it. It's 10 amino acids binding together. It binds into the GABA A1 receptor, which is the calming receptor, and has actually been shown to be 10 times more active than Ativan at quickly calming the body down. It does not bind into, though, the PBR receptor, which is the sedating receptor. So this can be used during the day. It can be used to squash cortisol levels at nighttime as well, but it's not a sedative, but that's a beautiful tool about it. The theanine that's in it, theanine is an extract from green tea, and it takes beta wave activity, that zip, into alpha wave, which is that calming. So one study specifically with respect to sleep is they took a group of Japanese patients and they used the Japanese Pittsburgh Sleep Index, which is a really extensive questionnaire, which looks at all variables of sleep, from did you take sleeping pills, how refreshed do you feel the next day, your memory the next day, how many hours you slept, every aspect of sleep you could think of. And they split people into two groups. One group took the Lactium and one group took a placebo. And they did this for 4 weeks. And what they found at the end of the 4 weeks was a significant improvement in all sleep variables in the group that took the Lactium. And again, from a single extract from milk, that's a profound effect to get right away. Interestingly enough, statistically, you would think there should be about a 50% placebo effect with the group that actually got the placebo. They had less than that of an effect with it. Just another note with Lactium, it was first isolated from breast milk. They noticed that babies that suckled with their mom, their cortisol levels dropped. They thought, well, is it because they're suckling with mom, or is it because there's something in the breast milk? So they put breast milk in a bottle, formula in a bottle, regular milk in a bottle, and the breast milk baby's bottle, their cortisol levels dropped most rapidly. Then they started playing around in lab, extracting the exact protein sequence, finding out that exact one, and now we don't make it from breast milk. We make it synthetically in lab, but that's how safe it is. That is, it is also the exact sequence that even as a baby who does not make any lactase to break down lactose does not have any issues with this. So again, from a dairy point of view. This is something that you also need to take on an empty stomach. Like most amino acids, you have to take this on an empty stomach because if you take it with food, it just gets lost in the food. I'll have a lot of patients say to me, well, if this comes from dairy, can't I not just have a glass of milk and get that effect? Not so much. That would be like saying, I'm going to increase eggs in my diet, so I'm going to eat cake. Yep, there's an egg in cake. But we don't eat cake and go, ooh, egg. You don't drink milk and go, ooh, casein tryptic tetrapeptide. So it has to be isolated on its own for the body to go, oh, this is that active ingredient that I do this with. Serotonin is also, or the Lactium, the only known ingredient that fully restores the hypothalamic and pituitary receptors. This is what gets our patients off the sympathetic treadmill back into parasympathetic mode. It does decrease the excess release of cortisol, adrenaline, and noradrenaline, and that's great. And literally within 24 to 48 hours, your patients will feel not sedated, not groggy, just coming down. But this is the only thing that is going to reset that HPA axis, so it's so important. Dosing is also really important. I'll generally start most patients with 2 twice a day empty stomach, because most people are walking through with really heightened stress levels. Once that we reset the HPA axis, we can drop it down to 1 twice a day. Genetics may determine whether I take them off 1 twice a day or the patient's lifestyle might. But it's really, really key. Melatonin, of course, we've spoken so much about that. we need to use this, not just to help us transition into stage 4 sleep, not just to help reset that wake-sleep cycle, but it is also what's going to help people like myself from jet lag, so shift over to timings faster. But it also does have, I mentioned that it's not a sedative, but it does have a calming effect, which is why when people take it, they are calmer, or they think that they're more sleepy going to bed. It's actually more calm. One of the ways that our body tries to fight sleep is by dopamine binding into melatonin receptors in the eyes. They're melatonin 1 and 2 receptors. And what that causes is this. It causes a blinking response, which then increases the release of our stress hormones to say, wake up. When you take melatonin, it will bind preferentially into those MT1 and MT2 receptors, not allow dopamine to bind in there, creating more calmness in the body. One of the side effects of a lot of the ADD, ADHD drugs which work through dopamine is what we call that blinking response. You'll see them doing this all the time, and that's because it's binding in. If you have a patient who's doing that, they need a higher level of melatonin to target the melatonin receptors as well. Melatonin also is one of the best antioxidants, anti-inflammatories for the brain. So as we mentioned, sleep, we need adenosine builds up through the day to make us feel more tired and inhibit excitation so that we're a little bit more sleepy when we go to bed. But if you don't allow yourself to go to bed and you fight it because you're working too many hours, then we can't get rid of the adenosine, because adenosine production is supposed to drop when we sleep. And when levels get too high, it's very inflammatory for the brain. So a higher dose of melatonin will also help to counterbalance the inflammation from building up of adenosine. It's also one of the main reasons that it's used in Alzheimer's and dementia for its similar antioxidant, anti-inflammatory effect. It also helps to control our body temperature. If you remember that one slide which looked at cortisol versus melatonin, and cortisol, what was the other one? There's body temperature in the middle, there's cortisol, so this is what jet lag was going to do too. Does anyone else can remember that slide? That's cortisol. It was cortisol and melatonin, but there's 3 of them. Cortisol and
Body temperature.
Body temperature is the middle one, but what was the one on the end?
Melatonin.
Cortisol. It's melatonin, body temperature, cortisol.
Oh no, maybe you're right. No, you're absolutely right. Okay, sorry. Wow, this is how sleep-deprived I am. This is what happened. Melatonin, as it's polar opposite to cortisol, it's also polar opposite to body temperature. So we need our body temperature to drop to go into a good deep sleep. So as melatonin peaks in the middle of the night, our core body temperature goes to its absolute lowest. And when they start to do this, warming up of the body is actually what also stimulates some of our wake-me-up hormones. Which is why they say sleep in a cooler room, it's better for you, it gives you a deeper sleep. If your core temperature is too high, again, you're going to mess up that melatonin. Melatonin, taking a higher dose of it, will help to moderate it. It's also extremely useful to help people go into that deeper sleep and moderate their body temperature during fevers or flus. So that will be another time where I'll want to increase the dose a little bit. So we have a bevy of different products for this one. We can start with the 0.5 milligrams. I'll use this with children. People will say, you know, how young can you start melatonin? We make it naturally. There is no feedback loop. So if there is even a baby who is waking frequently and they're not feeding, they're just cranky, they're just irritable, I'm actually going to give them Sereniten, which came from breast milk, and melatonin before night. You'd be amazed the difference in that baby. I will very rarely use a 0.5 milligram with an adult. Sometimes when somebody has been melatonin deficient for so long, they actually need to move more slowly, so you can't just jump them into a 3 milligram. That's where I'll start them on a 0.5 and then slowly move them up, but that's very rare. I'm usually, as a maintenance dose, going 3 milligrams. Cancer patients, Alzheimer's, I'm going 20. Flying over here, I did 9. If there's somebody who needs to cheat sleep a little bit, I'm going to go 6 to 9. But I'll generally never go less than 3 milligrams. And again, you can do it in liquid. The SR means the slow released. All of the other ones are quick onset. So if you have a patient who is has one of those defects with the clock genes and cryptochrome 1 gene, and they have difficulties falling asleep, using the non-slow release is actually better, because you're going to get more of its activation at the beginning, more of the calming through, less of the dopamine through the eyes, and more of that onset faster. If you have a patient who's waking at 2 to 4 in the morning, I'll often give them the time release. If it's a patient who has both, which is frequent with adrenal, I'll give them 6 milligrams, 3 milligrams regular, 3 milligrams slow release at the beginning of the night, so they get a mixture of both. Passiflora. Passion flower is a really underrated herb when it comes to sleep. It contains 2 main ingredients, alanine, which is an amino acid, and chrysin, which is a flavonoid. Both of these greatly increase the production of GABA. But it also has a third ingredient, an apigenin, which forces that GABA up into the PBR receptor and the A1 receptor. So we can give GABA to a patient, but that doesn't necessarily mean it's going to bind into the receptor. We know that when we give passion flower, it's going to make GABA and then take that GABA and put it into the sedating and calming receptor. And there's been a lot of studies looking at when they actually remove the active ingredient, particularly the alanine, none of the effects of sleeping were beneficial anymore. And again, smaller studies, but a study out of Johannesburg gave passion flower to patients, 30 people, right before bed, or a placebo. And once again, they saw that not only did all aspects of sleep with the passion flower improve, but their outlook the next day and their fear of sleep the next night was greatly decreased. And that's a big thing with people who can't sleep. It's the, oh my God, what's going to happen tonight? Am I going to be doing this all night in bed? And unlike a lot of the other sedating herbs, passion flower really helps to mitigate that effect much more so than other people. There was also a crossover study out of phytotherapy research where they gave people passion flower or a placebo for a week. Then they did a washout, and then they reversed it. So again, gave the placebo to the different group. And once again, only the patients who had the passion flower saw a better sleep, reduced anxiety, better outlook again the next day.
Passion flower always makes me really irritable.
Really irritable?
Which makes no sense, because whenever I've used it, I'm really ditched in it.
No, I would have to say that you would have a GAD1 SNP, that gene which converts the glutamate into GABA. And if you can't convert, sometimes what the body will take is GABA if it's low and push it back into GLUT1 with that gene. So you actually want to avoid anything that will increase GABA, not just passion flower. Did you find that one? Yeah. So theanine, really good for you. So theanine will really drop glutamate. So either straight theanine or Sereniten Plus, which has the theanine in it, that will really start to drop the glutamate. Then if you did take GABA, there'd be less of a need to shunt it back. But I'd probably still stay away from that and use other guys. So GABA, why do we want it? Apart from that it binds into that PBR and A1 receptor. It also inhibits firing down the central nervous system and into the muscles, so it stops rigidity of muscles, it stops overfiring and overexcitation within the nervous system. But you do have to be a little bit careful with it because it also increases IGF-1 and growth hormone. IGF-1 is insulin-like growth factor and growth hormone is growth hormone. And in fact, GABA can increase growth hormone by 400% during times of rest and 200% during times of workout. That's really significant. In the US, they are growth hormone happy. They're just giving growth hormone for, I don't know if it's legal here, it's not legal in Canada, and I'm thrilled that it's not. Growth hormone makes things grow, and it targets tissues that are most rapidly turning over first. It does not cause cancer, but if there is cancer in the body, that is the fastest replicating cell in your body, so it's like fuel to fire. Most people who are really sleep deprivant are very low in growth hormone and IGF-1 because we make most of it during sleep. So generally it's safe, but if you have a patient who has a strong family history of cancer, I would be a little bit weary, not with using passion flower because it's going to regulate out the GABA production, but with using high doses of straight GABA. Low doses, not a problem, but high doses. So I wouldn't go into the sort of 1500, I would keep it to around the 500 milligram with the GABA there. So it is needed though for sleep, absolutely. We cannot sleep without it. And what researchers did here was they took the cerebral spinal fluid of insomniacs and they compared it to the cerebral spinal fluid of non-insomniacs. And they genetically modified some cells to have a ton of GABA receptors. Then they took the cerebral spinal fluid from the insomniacs, put it on top of those cells in the petri dish, and we should see a bunch of firing electrical activity when the GABA binds it. They didn't see anything. Took the same cells, put the cerebral spinal fluid from the non-insomniacs on, they saw a bunch of firing. Then they put straight GABA on top of the cerebral spinal fluid, on top of, from the insomniacs, on top of the cells, and they saw all that firing again. So we know that it is the GABA that is much, much lower in concentration in insomniacs, which is part of the sleep picture, not the full sleep picture, but part of it. So Best Rest is a formula from Pure. It looks like this. It's in a big tub like this. It has the passion flower in it. It also has some theanine in it. It also has a small dose of GABA in it. It also has some melatonin in it. It also has a little bit of valerian in it, which I don't know if you've ever smelt valerian. Oh my God. So you can open up Best Rest, and if I'm opening it and my husband walks in like 10 minutes later, he's like, oh my God, you opened that bottle of stuff, didn't you? And it's pervasive. It works. The Best Rest formula I love because it really targets a lot of the different variables of sleep, but you gotta warn people, it smells horrible. You don't taste it, there's no after it, but it's like get it in, out, close it, because it lingers. Taurine. Taurine is an amino acid which helps all neurotransmitters bind into their receptors for a longer period of time. So it helps serotonin stay in the receptor and have an effect for a longer period of time. Cortisol, GABA, etc. Taurine is also needed to make both dopamine as well as melatonin in higher doses. So those people who are really low in taurine often again are the more anxious people. They have less calming, they have sleep disorders.
Can I ask you a question?
Of course you can.
Back 2 slides there.
Best Rest is death.
What is hops?
Hops comes from beer, but it's non-alcoholic. It has a sedating effect to it, and it has a slight increase in serotonin.
And is there any relationship to gluten?
No, it's all gluten-free. Yeah, absolutely. Hops can be extracted from a bunch of places, but we most often associate it with beer.
Should be sorry.
Oh, sorry, yeah. So serotonin, we saw the impact serotonin has with respect to depression. We also know that serotonin gets converted into melatonin. So again, if we don't have all these precursors for melatonin, i.e. the serotonin, we're also not going to sleep. So when we're giving a formula for serotonin, it's really important to give all the ingredients that we need to make it. So we saw with that one gene, TH2, tryptophan hydroxylase 2, if we're just giving tryptophan and hoping that that helps that patient's depression, and they have a SNP there, they're not going to convert it into 5-HTP. There's another gene, 5-HTTRS, which takes the 5-HTP and converts it into serotonin. If there's a SNP there, we're not going to get it. If somebody doesn't have methylfolate, or if they don't have enough B6 or zinc, those are cofactors that are needed for the progression of this. So we want to use a formula to boost that serotonin that has everything that we need in it, and what's kind of like the Best Rest formula. And that's where I'm going to go to the Sero Plus. So this has the 5-HTP, it has the methylfolate, it has the small bit of taurine, it's got the zinc, it has everything that we need to increase that serotonin production and skip over any of those steps. So when we're talking about hormonal production and genetics, the way that we fix that gene is usually by skipping over that step. So if the step is a problem of converting tryptophan into 5-HTP, I'm going to skip that step, give them 5-HTP. If the problem is converting 5-HTP into serotonin, well then we're definitely going to need the methylfolate, the B6, and the zinc on top of the 5-HTP to push it. And that's the beauty of Sero Plus, is it has all of it in once. Technically, I find I will never start somebody with lower than 2 capsules twice a day with the Sero Plus. Best rest, I should go back to that one. Sorry, just very quickly. I will generally start patients with 3 capsules about 30 to 40 minutes before bed. This has melatonin in it, so we don't need to increase melatonin unless we want to go above that 3.5 milligrams that we're going to get in the 3 capsules. So if somebody wants to add in extra time released or a higher dose, I'll just then add in an extra 3. You want to give any sort of sedating formula about 30 minutes to 45 minutes before bed, because people who are anxious about sleep, if they take it right when they get in bed, it takes about 30 minutes to start to act, and then by that time they're like, oh my god, I'm not asleep, and they've already just got themselves into that cycle. So if you do it 30 to 40 minutes, or what I'll do is, you might see me do this here, I will take this on my way as I'm leaving. If I'm out for a night, and I know I'm going to have less sleep because I don't have as much downtime, I will take it on my way home, so that by the time I get home, wash my face and it's embedded and it's in my body and I can go to sleep. Because otherwise, you need that sort of time to decompress. With the Sero Plus, I'm always going to start 2 capsules twice a day most often. Very rarely will I start with less than that. 5-HTP this is one formula, this is one amino acid, 5-HTP, where you actually can take it with food, get a full absorption of it, and it's actually often easier on their body. 5-HTP can actually aggravate a lot of people's stomach, make them feel a little queasy. If you take it with food, even better. Some patients are absolutely fine taking it on an empty stomach, and if they do, it's not a problem. There's no benefit outside of the nausea feeling to taking it with food, but it's just one that we can use either way. This is something that if they are on an SSRI or an antidepressant already, you can still use. There's going to be a receptor competition for this. So if we have, let's say, 20 serotonin receptors, we've got more, we'll say we're 20, they're on an antidepressant, about 18 of them are filled up with the antidepressant. Then we throw in some Sero Plus here. Sero Plus is definitely going to fill those last 2, but it's going to compete with the antidepressant and kick out the antidepressant from some of them and put in Sero Plus, or that version of serotonin. That might not be as strong as the antidepressant at first. So this is a way to help wean people off of antidepressants, but it's also a way to teach their body how to make serotonin while they're still on it, because what they've learned for so many years of the antidepressant is, I don't have to do anything, because here comes this production of it. So this is a way of teach the body, make it, we still have about a 70% binding with just the antidepressant, and then we slowly start to swap. You can never, ever take somebody off of an antidepressant without treating the stress hormones. It is impossible. You will see them, they're fine, I'm going to come off of it, they start to come off of it, and it all fails. You treat the HPA axis with the serotonin, you get at the why they weren't making and binding the serotonin. You may need to temporarily use some Sero Plus as well to teach that. Then coming off the antidepressant is a breeze, because they're back at the parasympathetic side of the nervous system and making their own and not inhibiting its production. Dopamine, similar to serotonin, we've got several steps. We've got several different genes which also go in with these different steps. So again, a lot of people will use just tyrosine or just phenylalanine and go into dopamine production. If your genetics are perfect, then 9 times out of 10, in that perfect case, you can get dopamine production. But why would we do that when, again, we have a formula which is going to give us that methylfolate, the B6, the zinc, the copper, all of it in one formula, Dope Plus. Here is where I will not take the tactic that I do with Sero Plus. I'll actually start them lower. I'll start them on 1 twice a day, and then slowly move them up to 2 twice a day. I may even move them up to 4 capsules twice a day. Here it's going to be an empty stomach, not with food. And just in case you're worried, all of the treatment protocol cheat sheets, they're coming up in slides after the case studies. So you don't have to worry about which is with food and what dosing, etc. But because somebody who has not made a lot of dopamine needs this, and they're genetically the ones who have very low dopamine, if you suddenly give them a ton of it, they're going to take those dopamine transporters and put it all here. So we have to slowly teach them, keep it in the prefrontal cortex. So we want to go with slow dosings with that. ADR. So we saw on how we get a patient back to the parasympathetic side of the nervous system with Serotonin Plus. But what about, and the patient who is hyper and hypoadrenal, they are both stuck in the sympathetic side. It's just that the hypoadrenal patient isn't making the adrenaline, noradrenaline. So there's not that energy, there's not that zing, there's not that get up and go, or the heightened anxiety with it. These are the people who are tired all the time, they're lightheaded on standing, but they're still stuck in sympathetic drive. So we still need the Serotonin to get them out of sympathetic drive, but now we need to get those glands, we need to give some life back into those glands that have crashed. So my favorite is going to do is ADR. We have adaptogenic herbs in here, but it takes, to use an adaptogenic to treat a low thyroid, takes months to get a good effect. Whereas if you use a glandular with it, you're gonna get that effect and start to see it literally in 7 to 10 days. So I'm always gonna go with a formula that mixes both of them. An adaptogenic formula alone is not going to reset the patient, putting them back into parasympathetic. It's just gonna slow down the sympathetic drive. They're wonderful maintenance guides. They're wonderful additions to the glandulars or to Serotonin, but you've got to tag team them both. The adaptogens alone will not get patients out of sympathetic.
Please tell me the function.
Of licorice root, it does a couple of different things. It vasoconstricts, so people who have low adrenaline, noradrenaline, they're very vasodilated. So this has a direct effect of vasoconstricting, so it starts to increase the oxygen, and it also alters the renin-angiotensin, so the sodium-potassium pumps through the kidneys, again helping to elevate the blood pressure. So its effects are more secondary, the symptomatic part of the adrenal, less of an effect directly on the adrenal.
Wow, is actually ginseng a vasodilator?
No, it's vasoneutral. Yeah. So probiotics, we have to get at those guys as well. There are a couple of different strains, the Helveticus and the Rossel, which are more specific for controlling serotonin production and dopamine production in the bowel. So again, if we see patients specifically with that, we might initially want to look at the ProBioMove, which is just higher doses of those strains. But in general, we need to really give a good whack of probiotics too, because cortisol has been killing them off. So my favorite go-to there is ProBio 50. This has a bunch of different strains in it again, not as specific for serotonin and dopamine, but it's 50 billion per cap, so a really good dosing system. Really important to use probiotics with food. If you take it on an empty stomach, often we're too acidic when our stomach is empty, and the acidity will kill the probiotics. So it's better to do it with food. And again, this is one place where more is generally better. So I'll often start people on 2 or 3 ProBio 50s a day, rebuild up that flora, and then start to drop things back down again.
I get confused with probiotics now. Some people say good, some people say bad, some say 6 months to make its way into the lining of the stomach.
So to get into the descending colon, you have to give such massive, massive doses. So that's a 50 billion. The doses to get down there are about 500 billion. The bigger effect is comboing them also with prebiotics to help feed and help the probiotic integrate down into it. So that's what the prebiotics, the different fibers will help to do. But look, with all the research now that's going on between microbiome transfers, etc., and with specific strains having very specific effects, and just even the studies that we saw in rats, how supplementing them with a lower dose drops the catecholamine production. I'm still a huge believer of probiotics. I work with a colleague who, that's all he does, probiotics, and stool analysis. And not a fun job, but he loves it. But I've learned a great deal from him in terms of the efficacy of probiotics, how to get them properly down into the different targeted areas. And then again, quality. So again, with Pure, they're all coated with a polysaccharide coating, so that they're not going to be broken down in the stomach from the acids. They're going to get right to the small intestine, which is where they really want to start proliferating. Okay. So case studies. First was let me take this one. Oh, I'll go quickly. Sorry. 47-year-old female, mother of two, works full-time. She was very happy and optimistic her whole life, and she got a large promotion at work. So all what looked like good stressors. But then she started worrying about her ability to keep up. She started getting heart palpitations, particularly when lying down, and she was anxious. She was quick to anger with her family, followed by a lot of withdrawal and seclusion. She started having difficulties falling asleep. It would take her about 2 hours, and then she would wake at 3:05. You'll see with patients, they can often time it down to that minute. She was taking Imivane and Ativan, but none of them would put her to sleep or keep her to sleep, moreover, and she still had the racing thoughts. When we looked at her genes, she was heterozygote for ADRA, so she made a little bit more than the normal amount of stress hormone, but her CRCH, she was variant, so she made a lot of CRH, just saying all the other come on out stress hormones. And don't forget, our adrenals are triggered with positive and negative stress. So the fact that she got a job promotion, all of those good things, those were the initiating factors that started to trigger these stress genes, which then started to trigger her TPH2 gene, which she doesn't make any serotonin. So prior to this stressor, she hadn't turned on her TPH2 gene yet. So her serotonin levels had sort of stayed, which is why she was optimistic. They'd stayed flatline or baseline. Now it was all being blocked. And her cryptocode 1, she was also heterozygote, so she had difficulties transitioning from one stage of sleep to the next. Up until this point, up until this big stressor, she had kept, through healthy lifestyle, most of her genes in their ideal position. Then stress came and went. So we have to use the Serotonin Plus here. We're going to do 2 capsules twice a day on an empty stomach. Temporarily did the 2 Sero Plus twice a day with food. It feels usually better with carbohydrates. Melatonin, we used 3 milligrams about 45 minutes before bed. And then we got the extra 3 milligrams with 3 capsules of Best Rest 45 minutes before bed. Within 48 hours, her racing thoughts and anxiety dramatically dropped. That's the Serotonin Plus. Within 2 weeks, they were almost gone. It's that fast with that formula. Within 3 days, she was falling asleep within 15 minutes as opposed to the 2 hours. 10 days later, she woke less frequently. And if she did, she fell back asleep quite quickly. A month later, she was calm, sleeping well. She felt like herself again. So this is when we started to reduce the Serotonin Plus to 1 twice a day, and the Sero Plus to just 2 a day as opposed to 2 twice a day, and then just using Best Rest as needed for those nights where she started doing this. 16 months later, she was still sleeping well, emotionally balanced, and happy even under stress. When you reset the HPA axis, your effects are long-lasting. It's not the, oh great, I got my patient to sleep for this week, and then they're awake next week. When you get at the cause of it, you fix all of the variables, and that's why I'm saying you can't address sleep without addressing stress. You can't address stress without addressing sleep or depression. They're all intertwined in there. This is a 14-year-old male. He grew up in a house where his parents argued frequently. His parents got divorced, moved across town, so he started a new school. He started having panic attacks before school each day despite being a straight-A student. He started waking at 2:30 every morning, and he couldn't fall back asleep. So he started, I don't know if cannabis is huge here, but it's huge in North America, especially if we're legalizing it now, and that's a whole other can of worms. But started smoking cannabis in the middle of the night, and soon found that he wanted it more and more in the morning and then all throughout the day. So that addictive behavior. He was tired all day, but he was wired all night. So when we looked at his genes, his stress genes, again, he made more than the normal amount of stress hormone. He was heterozygote for CRCH, so average amount of that hormone. Dopamine had very little. And again, those genes were triggered by stress with his family. So no wonder he wanted that cannabis, and no wonder he wanted more and more of it. His CLOCK2 gene, he was heterozygote, so he had real easy loss of circadian rhythms here. And his GAD1 gene was also heterozygote, so a lot of this going on, less common. So again, we've got to get at that HPA axis as we always have to do with the Serenitin. This time we're going to help support that dopamine so we can get them off that cannabis. We're going to use the Dope Plus 2 twice a day. Here I'm going to use the GABA before bed. So I'm going to try to help convert that glutamate into GABA because he was only heterozygote there. And then we're going to use that fast rest to fall asleep. His panic attacks reduced to just what he called anxiety in 4 days. Then they reduced to what he called worry in 9 days. And then any fears had gone by day 12. On the 4th night, he could fall back asleep within 10 minutes of waking. By the 8th night, he was sleeping most nights. He dropped his cannabis out by 10 days and he had no aggravation of sleep or mood when he did this. A month later, we dropped the Serenitin dose in half, increasing it as needed on stressful days. We reduced his Dope Plus to half for another month and then kept him off. But I kept him on the GABA nightly because of the 1 gene and then the best rest. 2 years later, he's still sleeping, no panic attacks, and feels well. So again, with our patients, if we're not going to see this fast effect as well. You treat all variables of it, things move quickly. You treat one variable of it, it's like, oh, they're sleeping a little bit. And it's like 6 months later, then they're sleeping through the night. I can only guesstimate that Hong Kong is worse than Toronto, and we want it now. So, do you want me to go into this case? We're still okay for time. This is a 56-year-old female. She's 5 years postmenopausal, but at the 5-year mark, she started waking exhausted and having sweats in the middle of the night where she would actually soak her nightgown. Her father had passed away 3 months prior to this. She was anxious most of the day since this, worrying about her family's health, but yet tired all day. She frequently experienced lightheadedness on standing, and she had increased digestive gas, bloating, but it wasn't associated with any food. When we hit menopause, just as naturally as estrogen and progesterone and testosterone fall, cortisol rises. So we start making more stress hormone for the same stressors than we did premenopausally. So she never had any of the sweats or anything like that. Cortisol is a vasodilatory hormone. It opens up the blood vessels, it rushes all that blood to our extremities so that we can go fight that saber-toothed tiger. She was getting the sweats in the middle of the night because perimenopause, 5 years ago, it increased her susceptibility with cortisol, but nighttime sweats after her father died, being a big stressor, really triggered that. If you see daytime sweats with postmenopausal patients, estrogen is usually involved in that. If it's nighttime, then it's usually just cortisol. If it's both, then it's often both of them. So her address SNP, she was heterozygote, so makes a little bit more than the normal amount of stress hormone, but not a huge amount. Same with her cortical-releasing hormone. Her FOOT2 gene, this is the gene which deals with, do I let probiotics live in my gut and propagate, or do I not? And she was variant for this, so she didn't allow any of that microbiome to live. So when she had that stressor of her father passing away, cortisol went up way high, triggers this gene, and now we're letting even less microbiome live here, which then increases again the production of the cortisol, as we saw through the lecture going around. She also was variant for her COMP gene, which is the one that clears out the epinephrine, the norepinephrine, and cortisol. So now that she's also making more, she's also not clearing it out, which is why all of these effects happen. So once again, we have to treat that HPA axis. The difference between this and the other patients was that she was tired all the time and she was lightheaded on standing. I also tested her orthostatic blood pressure in office, which is that blood pressure test. You have them lie down and you take it, you have them stand up, and you take it again. Our blood pressure, when I'm down here to here, our blood pressure goes up by 10 points. And that's because adrenaline and noradrenaline and cortisol come out. They have sensed the physical stressor of gravity pulling blood away from the head. That's a stressor because we need oxygen to the brain. So they tighten up the blood vessels. Adrenaline and noradrenaline tighten. Cortisol opens up, but 2 out of 3 should win. And the blood pressure goes up 10 points. And that's our mechanism of how we don't faint every time we stand up. When somebody's getting lightheadedness on standing all the time, I often hear, oh, well, I have low blood pressure. I have really low blood pressure. It makes no difference. It's going to be low here. It's still going to be low here. It's the change from the adrenal response in that blood pressure that dictates how much stress hormone they're doing. So this is an easy, free way of testing a patient. Are you hyper or hypo? Hyperadrenal, where they make cortisol, adrenaline, and noradrenaline, all three of them, rather than just rising the blood pressure up 10 points, they're going up much more than that. I'll often see it in 40s and 50s, but sometimes it's just even 20. Hypoadrenal, they're not getting up the 10. They might only go up 5, or frequently I'll see them falling like 10, 15. And so when they stand up, there's no tightening of the blood vessels, only the vasodilation, and they're doing this. They have even less oxygen, so they have to wait till that centers out. So that's a real key, even symptom-wise, if you're not going to test, they have to have that ADR in there. You have to get a glandular in there while you're resetting the HbA axis. I'm going to use both here, the ProBio 50 and the ProBio Move. So again, I'm a big fan of probiotics and dosing high. And because of her FOOT2 gene, which likes to kill out a lot of the good bacteria, and her cortisol, which likes to kill it out, and her moods, we went with both of them. Within 3 days, her lightheadedness greatly subsided. That's the ADR. And anxiety was reduced by 50%. Within 5 days, she wasn't waking up soaked with, from her nightgown, or from the sweats in the nightgown, but she was still waking tired. At 12 days, she began to feel more rested on waking and increased energy throughout the day. At 2 weeks, her bloating significantly reduced. 3 weeks later, she felt more like herself again, very little anxiety, and was waking rested with a lot more better daytime energy. At 6 weeks, we reduced the ADR formula. This is definitely one you do not want to keep. You could keep somebody on Sereniten Plus for the rest of their life. Even if they're back in parasympathetic, it's not going to have an adverse effect. Once the adrenals are back to normal, keeping you on ADR puts them into overdrive. So you got to keep checking them, checking with their symptoms, checking with their orthostatic blood pressure. So at 6 weeks, she was back to plus 10. So we dropped her dose for 2 weeks and then dropped her off. Reduced her Sereniten to 1 cap twice a day. And then 2.3 years later, she's sleeping well, happy, increases her Sereniten Plus only on stressful days. So again, when you use genetics, but moreover, when you get at the true cause of the problems, you get the years of longevity of the treatment. You also get the trust with your patient. What I actually find is harder is saying you don't need this supplement anymore. They're like, no, I'm not going off of it. And again, sometimes it's fine. You can keep them on it. But sometimes we do need to, like the ADR one, encourage them to come off of that one. So just very quickly, hyperadrenal. What are the symptoms in case we're not going to do any of the testing? That orthostatic blood pressure is generally plus 15 or more. The key is that they have elevated cortisol, adrenaline, and noradrenaline. They have a lot of racing thoughts. They have difficulty falling asleep. They wake at 2 to 4 in the morning and they have a lot of heart palpitations. So a lot of the stimulation, a lot of the drive. You've got to use the Sereniten Plus with them. I'm often going to use the time-released melatonin with them. I'm often going to use the best rest on top of it, and sometimes the GABA. The opposite end of the spectrum, the hypoadrenal. This is where their orthostatic blood pressure is 5 or lower. They have a low flatline cortisol, but they have basically zero, adrenaline, noradrenaline. They're lightheaded on standing all the time. They're not racy like the hyperadrenal, they're low, they're tired. They might sleep 8 to 9 hours straight through, but they still wake exhausted because they're not getting into that stage 4. So here we're going to use that Sereniten again, reset that HbA, or we're going to get those adrenals going again with the ADR. NeuroPure, do you guys have NeuroPure here? Yeah. So NeuroPure is a formula which is a good booster for low levels of all neurotransmitters. So a little bit of dopamine support, a little bit of serotonin support. So we're getting a good balancing. Because the person who is hypoadrenal, their neurotransmitters are way off. Because by the time you've gone through hyperadrenal crash mode into hypo, their production has been really downgraded for a long period of time. And then I'm going to use a higher dose of melatonin, 6 to 9 milligrams for full day. Serotonin support. These are the depressed people, the people who can't find the joy in life. Not necessarily low energy, but low mood. It's darker. It's more the flight side. They crave the chocolates and the sweets, and they wake at 5. So again, we're going to fix the why with the Serotonin Plus. We're going to help the body start to learn to make serotonin again with the Sero Plus. We can, if somebody has an issue taking Sero Plus, we can go straight to 5-HTP. That is an option. But issue, I would say cost. Sero Plus is a little bit more expensive than straight 5-HTP, but my go-to is always going to be the Sero Plus. And then glutamine. Glutamine is a great amino acid to help with sugar cravings. So if you take glutamine in powder form, put it in water, swish it in your mouth for 30 seconds and swallow, it instantly kicks out sugar cravings. And because the low serotonin people crave sugar, this is a great technique to help get them off of it. Glutamine saturates the sugar receptors on the tongue, and it disinhibits that messaging system from the tongue to the brain saying, I want some more sugar, please, I want some more sugar, please. So I'll give it to patients if they know that at 3 in the afternoon they always want a sweet treat. I'll give it to them at 2:30, but they have to swish it in their mouth and then swallow. If they then at 5 still have another sweet craving, they can take it again. It's really difficult to overdose on glutamine. Generally, going beyond 8 to 10 grams a day for the average individual I wouldn't do, but if you're only using 500 milligrams per dose, that means that you're doing that 16 to 20 times a day. We've got a whole other load of issues that we need to address outside of just glutamine. Dopamine support. This is that person who's looking for reward, particularly at the end of the day. They want those fattier foods, the cheese, the chips, the wine, the alcohol. They have that addictive behavior, whether it's shopping, whether it's a good one of exercise, whether it's gambling, and they want those adrenaline rush type sports. We're going to use the Serotonin, again, fix why they're not making the dopamine. Use the Dopa Plus to help teach the body to make the dopamine again. Or we can also use just straight tyrosine if somebody doesn't have access to, or the Dopa Plus, tyrosine is cheaper. We can use that as well. Sleep support. So a couple of different areas. If the issue is falling asleep and waking in the middle of the night, we have to fix the why again with the Serotonin Plus, where you're going to use the best rest formula to get into that GABA PBR receptor. And here I'm going to use the time-released melatonin. If the issue is sleeping through the night, sleeping a ton of hours, but waking unrested, so again, they're not going into any stage 4. This is that hypoadrenal patient. We're going to use the Serotonin Plus. We're going to use the ADR. And here I'm just going to use the regular melatonin. You don't need to. You can use the SR, but you don't need to for this patient. The next group is the ones who have difficulty sleeping, but they're waking at 5 a.m. So this is that low serotonin person. So again, we fix the why with the Serotonin Plus. We teach them to make serotonin again on their own with the Sero Plus. And here, because I want to target more of the later hours, I am going to use the time-released or slow-release melatonin. I apologize for going over. Are there any questions?
As regards CBD, when I was covered, a lot of athletes now are taking it for anxiety and whether it's antioxidant or anti-inflammatory.
Huge anti-inflammatory effects, absolutely. Huge anxiety risk as well. Genetics will really show us who it works for and who it doesn't. The one good thing is that it generally doesn't have too many adverse side effects. It just won't work for those people who are genetically not disposed to it.
Sorry, when you say it generally will have too many side effects, what side effects are there?
A lot of people get a lot of headaches, a lot of pounding headaches from it. Some people it actually can increase the anxiety, but I've only seen that in patients with SNPs on certain genes, on the cannabinoid receptor genes.
Is that a low percentage?
Very low, very low. My issue with it, if it doesn't have THC in it and it's just the straight CBD, I have no issues.
From hemp?
Yeah.
From,
Yeah. Even if it comes from marijuana and it's the THC, which is the sort of psychoactive ingredient, is extracted, I don't have an issue with it because then you're just getting the anti-inflammatory, nerve regenerative properties. It's the THC side that I have an issue with, mostly because it's also a gateway drug. So in Canada, they're legalizing it. And I find that it really irresponsible, because you're going to have young kids now who are like, oh, great, it's safe. So pot's safe. Well, acid might not be that bad too. Whereas when pot was illegal, it was like, okay, this is illegal. I definitely won't go there. But from a dopamine point of view, it is a gateway drug. Particularly for the studies show to up to age 30. It has less of an effect as a gateway drug over age 30. But again, that's only with the THC. Now, a lot of the anti-inflammatory effects are really upgraded when you have the THC with it. So it is a bit of a catch-22. For chronic pain and for sleep and insomnia, I don't have an issue. But it also doesn't treat the why. And it's mopping up symptoms again. So if you tag team it with Serotonin initially, you fix the why, then you can get them off the CBD much faster.
Why is you're an athlete and you train a lot in
So
that context?
absolutely. So I used to do race running nationally. I used to train at the training center, and I would just instill what I'll do is I'll cheating things. I'll cheat my training. If I want to do a really long workout that's going to up my cortisol, I'll take 2 Serotonin before it and 2 afterwards.
It's amazing. It's in every side effect.
It has changed my practice entirely, because 90% of visits to doctors' offices are due to stress or stress-related disorders. And this is the only nutrient, and I've researched this for years and years and years, that resets the HPA axis. Our body knows how to heal in parasympathetic side. It doesn't create those inflammatory products. It doesn't do all of those things in parasympathetic. Now, when you're exercising 4 to 5 hours a day, it might not be just the cortisol-induced inflammation, it's also regular inflammation. So that's where cannabis oil can help, but you can also increase the clearance of those inflammatory guys through liposomal glutathione, NAC, resveratrol, NRF2, which all upgrade phase 2 detoxification, which is binding to inflammation and yuck and taking it out. So,
And those things are found in
no, those are separate products. So they are pure products as well. Liposomal glutathione and NAC, they're probably, next to Serotonin, they're 2 of my most favorite products. Because you can never, we are so exposed to toxins in this world, you can never support your body more. You can't overdo phase 2, you can't over clear out stuff in the body. So glutathione is our body's major free radical scavenger, it's our major clear out guy. And NAC, N-acetylcysteine, increases the production of glutathione. So you always want to give them together. If you give just glutathione and the body is low in cysteine, it's going to steal the cysteine from glutathione and render that glutathione inactive, because cysteine does a whole bunch of other things in the body besides glutathione. So you always want to give them together, and you get a really good anti-inflammatory, anti-aging, phase 2 detoxification effect.
So, and then what about in whey protein?
Absolutely. So you're going to get glutathione precursor there as well. Absolutely. So again, because in whey protein you have the full more than 12 amino acids, if somebody does have a dairy sensitivity or whey sensitivity, they can't use that as a precursor to glutathione, which might be a little bit more of an issue over here, again, just genetically. I don't have an issue with it. I use it every day.
Would you be able to comment about adenosine supplementation?
Adenosine supplementation?
So, yeah, I've seen it around, but I haven't really ever been able to find either some proper protocols, or, and as you said, like in high doses it can be.
That's exactly it. So if you don't sleep, adenosine is going to become pro-inflammatory, because we have to clear it out of the body. So if somebody is not, adenosine builds up through the day, but if they are doing shift work, and so they're not exposed to sunlight hours frequently, their adenosine production is going to be very low. So that would be a place that I'm going to increase adenosine production there. But if they then start sleeping long hours, I'm going to definitely take them off of it, because they're not going to be able to clear it up.
There were 2 reasons why I was looking into it. Primarily, seeing airline stewards here is quite a big one, and that was one
Absolutely.
issue. The other one is that there are, people do love coffee here, and there's quite a big kind of caffeine thing, and I'm not immune to that.
No, absolutely. So
Uh,
caffeine is actually, adenosine will bind to a little bit of caffeine and pull it out, but caffeine is cleared out through a gene called CYP1A2, where curcumin really slows down that gene. So if somebody is drinking a lot of coffee, I'm actually going to take them off curcumin because that's going to decrease their